all to yet another important webinar on resistant hypertension, easing the burden through awareness and innovation. Hypertension remains one of the most significant contributors to cardiovascular mortality in India, accounting for over 57% of stroke deaths and 24% of coronary heart disease deaths. This is from ICMR according to the survey 2020. Among these patients, a growing number suffer from resistant hypertension, defined as uncontrolled blood pressure, despite using 3 or more antihypertensive medication, including a diuretic. As we mark May Measurement Month, it's a powerful reminder of the silent yet serious impact of high blood pressure. While many cases are manageable, resistant hypertension presents new challenges that call for multidisciplinary solutions, advanced diagnostics, and targeted therapies. Let's commit to helping patients take control and reducing this hidden burden. That's why we are conducting this webinar, which is awareness oriented as well. So let me quickly introduce the 3 leading cardiology experts today who have joined us for this webinar. We have amongst us Dr. Keyur Parekh, Chairman and Senior Interventional Cardiologist, Maringo Sims Hospital, Ahmedabad. Thanks a lot, Dr. Parekh, for joining in. Next, we have Dr. Arun Gopi, Director, Cath Lab and Senior Consultant Interventional Cardiologist and Electrophysiologist, Metromed International Cardiac Center, Calicut. Next, we have Dr. Sridhar Kasturi, HOD, Cardiology and Cardiothoracic Surgery and Senior Consultant Interventional Cardiologist, Kim Sunshine Hospitals, Hyderabad. So we have all the 3 expert panelists will be talking about very important and crucial and pertinent topic of hypertension. So let me go to Dr. Parekh first. Dr. Parekh, as per study published in the Journal of the Association of Physicians of India, 1 in 5 hypertensive patients in India have resistant hypertension. What does this reveal about the treatment access and approach? Over to you.
Well, first, as you already mentioned, resistant hypertension is blood pressure more than 140 systolic, 90 diastolic, despite taking 3 medications. So firstly, we want to ensure that patients are indeed taking the medications, there is adequate compliance, and this is not a transient situational hypertension, or as we sometimes call pseudo hypertension, or hypertension just because patient has come to the clinic and is under stress. So we need to do an ambulatory check on these patients. Having done this check, traditional way was to keep on increasing the medications from 3 to 4 to 5 medications, of which many times patients stop the adherence mainly due to either side effects or lingering and continuing cost of the drugs, and or difficulty in general compliance because of the timings of the medication. So considering all that, it is one of the most difficult situations. And as you mentioned, significant percentage of general population who has hypertension does have resistant hypertension.
Going to Dr. Gopi, despite high awareness, only 1 in 4 hypertensive Indians have controlled blood pressure. Could underdiagnosed resistant hypertension be a major factor? How do you see this?
Yeah, so if you tell one of the risk factors for cardiovascular disease, which has maximum impact on the lifespan as well as morbidity, it is clearly hypertension. We call hypertension as a silent killer because most of the hypertensives don't have any symptoms. So the only way to detect hypertension would be self-monitoring of blood pressure or get it frequently evaluated. So if you look at the facts, in fact, overall, if you look at the whole people who are hypertensive, only 50% are actually diagnosed to have hypertension. And among them, only again 50% are getting it under control. When we say that under control, we mean that the blood pressure is reaching the target level of 140/90 in a normal person, or in a diabetic, keeping it less than 130/80. So this is going to happen unless there's a self-monitoring of blood pressure, which can be done with a home blood pressure monitor, or they go through an ambulatory blood pressure monitoring where they have equipment attached to them and the blood pressure is frequently monitored. Most of the time, blood pressure would be missed. There's some entity called masked hypertension, where the people would be having hypertension, but in the clinic, the recorded blood pressure would have been falsely low. So that will also lead to an underdiagnosis of hypertension. The contrary for that also exists. Some people are generally normotensives, but when they reach an hospital, because there's stressful environment there, seeing the doctor, they might develop a higher blood pressure, which is called white coat hypertension. So both these entities and all need to be clarified. So the first thing in the diagnosis of hypertension is to have frequent blood pressure checks, preferably at home, and to have multiple readings done, and to have at least 3 readings more than 140/90 to diagnose him as a hypertensive patient.
Okay, so let me quickly go to Dr. Parik again. Dr. Parik, are we seeing any increasing incident of resistant hypertension in younger adults, or like is there any specific age group which is of more of this RHTN issues, and how concerning is this trend from a long-term cardiac health perspective?
It's a very good question. Again, if you look at the population of India, close to 1.4 billion, and significant of our population is now what we call as young or middle-aged, who are the most productive, most important part of society. Interestingly, high blood pressure and also concomitant coronary artery disease is progressively, rapidly increasing in this group. And there are a number of reasons. Some of the very common reasons are increased stress, increase in dietary indiscretion, or I would rather call it increase in prosperity leading to increasing dietary indiscretion. They go together. Increase in salt intake, increasing in sedentary lifestyle. Unlike Western world, which learned their lessons, sedentary lifestyle is still very predominant in India, significantly in a younger and middle-aged group, where they just do not exercise. Along with that is just increasing obesity, which all of this in combination does lead to significant hypertension. And in this patient group, all groups, but especially the most vulnerable group in terms of impact on their lives and impact on their families and impact on society is going to be the younger group as well as the young middle-aged group. So we are talking of ages of 30 onwards to 50, 60. And I'm really seeing much more prevalence of high blood pressure in younger people coming to my clinic who are in the ages of 25, 30-ish, 35. Now, usually they do come with a controlled hypertension with single drug, double drug, but over the time, either they become resistant, either because of any of the 5 reasons I mentioned earlier, or along with that, they keep on increasing their weights, continue with sedentary lifestyle, continue with stress-induced lifestyle, that these people get resistant hypertension, and on triple medication also they don't get controlled. When this happens, the most important thing is this high blood pressure, especially resistant high blood pressure, strikes in 3 places: brain, heart, and kidneys. Invariably, even with a simple hypertension, all these 3 are affected, except they are subclinically affected either with microischemia in the brain or with what is called as LVH, left ventricular hypertrophy, which is thickness of the heart wall, or kidney will start showing atherosclerotic or slight aging in the kidneys because of hypertension. And along with that, hidden is always the retinal or eye changes of hypertension and peripheral vascular changes. When this is uncontrolled over a prolonged period, absolutely 100% it does affect these 3 organs in any variable sequence, and that leads to morbidity and significant limitation in lifestyle. So at the end, this vulnerable group, unfortunately, is also the group which does not go to doctors routinely, is most non-compliant because it's a silent, as Dr. Arun Gopi said, it's a silent disease, very silent, that this has to be targeted through very regular aggressive checkup.
Okay, let me go to Dr. Sridhar Kasturi. Dr. Sridhar, we were talking about like, are we seeing increasing incidence of persistent hypertension in younger adults, and how concerning is this trend from a long-term cardiac health perspective? So, Dr. Parik was talking about the dietary discretion and about the drugs as well. So, what is your take on it?
I think Dr. Kair Parekh, he described in detail almost all the important points discussed. See, resistant hypertension, most of the time we underestimate. One is because the uh, many times doctors, it's the problem from the doctor side also. They don't check frequently and easy taking drugs regularly or not. Complaints of the drugs are there or not. Easy maintaining the good exercise and dietary modification. So all factors to be considered, the proper recording of the blood pressure, these are all important. Overall, if you take the hypertension patients, 15 to 20%, they come under resistant group. Even in the resistant group, 5% are refractory. When do you say resistant? Despite using more than 3 drugs, if the systolic blood pressure more than 130 and diastolic more than 80, so if more than 5 drugs, then we say refractory. So recently, one of our patient, we have given 5 drugs. Despite 5 drugs, pressure was uncontrolled, 170, 100. He was continues to have episodes of headache, and previously underwent angioplasty, 76-year-old. And as Dr. Parekh mentioned very clearly, see, hypertension, many times it's a asymptomatic silent. So 90 to 95% of the patients, they will not have any symptoms, no symptoms, because that they tend to ignore the problem. And at the same time, even if the doctor prescribes the medications, there may be some patients may not tolerate drugs. Some side effects may be there. Suppose thiazide fatigue may be there. Beta blocker fatigue may be there. So the IC inhibitor, they may have a dry cough. So these complaints, instead of telling the doctor, if they meet the doctor, they change they change the medications according. But sometimes because patient is asymptomatic, they try to avoid the medications. But the problems are many if they stop. There is a 50, if they take regular medications for hypertension, there is a 50% reduction in the heart failure, 50% reduction in the stroke, and 27 to 30% reduction in the MI. And renal failure, worsening of the renal failure, you can decrease it by 50% when you treat it aggressively. And hypertension in middle age group, if you are treating regularly, adequately, and usually it prolongs the lifespan by 3 years. So many times we underestimate the amnesia in old age. So if they take regular treatment adequately, if they control from early age, the chance of losing, chance of preventing the amnesia is by 50%. So heart failure can be prevented, stroke can be prevented, end-stage renal disease can be prevented, amnesia can be prevented. So there are many benefits of hypertension. Sometimes we see cerebral stroke, maybe because of the bleed or ischemic stroke. You see many, if you see the globally, it is, if you take the non-communicable risk factors in WHO, this is the #1 killer. Hypertension is the #1 killer. So almost it contributes to almost 10 million deaths across the globe. So a very high incidence, even in India, if you take 100 million patients are with hypertension. So the magnitude of the problem is very high. But the only thing is lack of awareness. At the same time, doctors are also too busy. Sometimes the awareness of the doctors also, even if the 140/90, sometimes, okay, you can continue the same medication. Now, particularly after sprint study, more aggressively if you control, if you achieve the optimal blood pressure level, like the less than 120, 70 to 80, diastolic pressure, the study has shown very clearly significant MACE reduction, even when you have a patient's less than 120, 120, 130 also. Compared to 120, 130 systolic, their MACE rate is much lower. So that's the reason hypertension, lifestyle style modification is mandatory, adequate treatment, and continuous treatment. So irregular treatment is more dangerous, and it's same drug combinations can be tried. If more number of drugs are taking, sometimes what happens, the patients are reluctant to take more if they are writing 3 or 4 drugs. And at the same time, doctors should sit with them. They have to explain about the importance of controlling the blood pressure, and so that they can avoid the future complications like a stroke, myocardial infarction, cardiac failure, ACS, renal, end-stage renal disease. All these things can be prevented. So ideally, in resistant hypertension, despite giving medicines, then renal denervation definitely is a one of the best therapeutic modality, alternative therapeutic modality. So at least the studies have shown very clearly, as at the end of 3 years, global the simplicity trials, hypertension, all these trials have shown very clearly consistent reduction in the blood pressure. That is 10 to 15 millimeters of mercury, even at the end of 10 years. There are two small investigator-based trials that they studied on 30 patients and 60 patients. They showed consistent reduction even at the end of 10 years also. So that's the reason at least you can eliminate 1 or 2 drugs, especially if patient is requiring 3 or more drugs. But some patients are very reluctant to take, poor complaints, intolerance to drugs due to because the side effects. In such cases also you can give a alternate, particularly young patients. When young patients, sir, how long I should take drugs? At this age, do I require medications? In such cases also you can suggest, this is not the indication, but ideally resistant hypertension definitely it's indicated. But we should emphasize more on the lifestyle, good diet, good exercise, and potassium rich the green leafy vegetables, and avoiding and taking avoiding the alcoholic binge. Young patients, one of the most common cause excess alcohol. That is also, and overweight, especially cut down the weight. These are all important factors, but many times we'll give drugs. We don't focus on lifestyle modification. And these are all definitely play a big role in controlling the blood pressure.
Thanks a lot for that elaborate answer, Dr. Sridhar. So now we had spoken about the prevalence. Let us slowly go to the awareness. As Dr. Sridhar said, and Dr. Parekh and Dr. Gopi had said, like asymptomatic. Being asymptomatic itself shows that how much awareness is needed, because a common man like us would not know whether we are into this resistant hypertension bracket. So let me go to Dr. Parekh. How is resistant hypertension clinically defined, and how do you distinguish it from pseudo-resistant or true resistant? You had earlier spoken about the pseudo-resistant. Dr. Parekh, over to you.
Yes. Again, this is very much, I'd like to repeat what I mentioned earlier, that if the blood pressure stays more than 140 by 90, actually recent criteria has become stringent to 130 by 90. And some people truly believe that at any age, the blood pressure ideal normal is around 120 by 80. I'm of that belief, and I have a 94-year-old mother, because I think time has come, we should start telling little stories. I have a 94-year-old mother who gets headache when her blood pressure is 135. So for last many years, I've been managing her blood pressure from her request to be kept around 120 to 130. The lesson here is, for many decades when we were in medical school, and I believe Dr. Sridhar, Arun, Gopi, we were always told that as you grow older, they had all this formula related to age, that okay, 150 is okay, and still lot of doctors make you believe that 150 or 160 or 170 is okay. All the clinical data shows it's not okay. All age-related relationship of hypertension has gone down to an absolute number, which Dr. Sridhar mentioned, around 130, and some even believe even lower. So if you look at that number, then we are talking of a massive, large population with hypertension. Now, among those, we just have to be clear to have them check their blood pressure at home. Very easy electronic devices. They're fairly reliable. And I tell the patient there is a 5-10% variation, don't worry, it will still give you a clue. They are battery operated and they're very easy. My mother, 94-year-old, if she can check her blood pressure twice a day, which is, I think, too much, I think everybody can check it at least once every other day, once every third day. So I give the example of my mother. She's an alive example. Number two, we just make sure they're compliant with their medication. Third thing, I start teaching these people that basically there is a body which has small nerve fibers in the body. They are sympathetic nerve fibers. And the kidney arteries have these sympathetic nerve fibers. And these nerve fibers sometimes get overactive. When they get overactive, they go and connect to the brain and make sure that brain gets overactive in certain areas. When this happens, brain connects to the body and the sympathetic system. These are these nerve fibers, and it ends up releasing four different kinds of hormones. One is renin, another is renin angiotensin, angiotensin 2, third is aldosterone, and four is the adrenaline, like if dog runs behind you. So I explain to the patients and sometimes write down these names, tell them that this blood pressure is related to these hormones. And unless you take your medicine, well, these hormones will start killing you eventually. So this is a real fact that resistant hypertension is there. It's underdiagnosed, undertreated. And as Dr. Sridhar Kasturi mentioned, lifestyle modification, etc., has to be done. In Gujarat, we don't have alcohol. The rumor is we still have the highest consumption of alcohol, but in Gujarat, we don't have alcohol. So officially, I don't have patients who claim they take alcohol. But yes, but one thing now I really want to emphasize, it is almost impossible to change lifestyle. And trying to spend too much time and effort is very difficult. I will not say impossible, very difficult. People don't change their lifestyle. People don't change their eating habits. People don't go on a salad-based diet. North India, South India, East India, we have here Calcutta, we have Calicut, we have Delhi. Everywhere you go, restaurants has become prevalent. Sedentary lifestyle does not change. Prosperity-induced obesity doesn't change. And as we know, we are diabetic capital of the world and we are also hypertension capital of the world. So at the end, it will be treatment, either drugs or eventually we will have to convince patients, as we mentioned about angioplasty, bypass surgery, that there is a technology called renal denervation. And it is the only technology which can affect and reduce all of these four hormones through a single methodology, which we will discuss later on.
Yeah, absolutely. Thanks a lot, Dr. Parekh. Let me quickly go to Dr. Gopi. Dr. Gopi, how significantly does resistant hypertension contribute to cardiovascular events like stroke and coronary artery disease in India? If you have any numbers, also you can share.
As it has already been alluded to, hypertension is the single most important risk factor for stroke. So if you look at the leading cause of stroke, it is simply hypertension. If you look at the leading cause of chronic kidney disease, it's again hypertension. If you look at the leading cause of heart failure, it's again hypertension. Among myocardial infarction, people having heart attacks, it is one of the major key players as a risk factor for hypertension, for myocardial infarction as well. So, see, hypertension, the problem is it is undiagnosed, it is untreated, people are non-compliant, it's there for long term. It itself causes actually damage to the blood vessels of the brain and heart, which causes what is called atherosclerosis, which is nothing but the deposition of the bad cholesterol or the LDL cholesterol, oxidated LDL in the blood vessels, which actually gradually accumulate and actually starts limiting the blood flow in both the cerebral circulation, that is the blood vessels to the brain, as well as the blood vessels to the heart. Gradually, they become stenotic enough to cause symptoms. And at one point of time, they would have ruptures when these vulnerable plaques rupture. And one of them would actually end up with a myocardial infarction or heart attack, and another person might have a stroke. On the contrary, in the cerebral circulation, it causes both ischemic stroke as well as hemorrhagic stroke. That is, you can have these small blood vessels which could actually rupture and cause a bleed in the brain. as well as it could be a block of these blood vessels, which actually cause loss of blood circulation to the brain cells, causing an ischemic stroke. So among stroke, stroke and renal failure, hypertension is the single most important risk factor. But at the same time, for myocardial infarction, also hypertension is not lagging behind diabetes or smoking. We are all unfortunately genetically predisposed for malignant form of atherosclerosis, having most of these premature atherosclerosis in all the vascular territories at least a decade earlier compared to our Western counterparts. So with having one more risk factor like hypertension, you would increase your risk of stroke as well as MI significantly. If you look at a person having a blood pressure of 120 and a person having a blood pressure of 140, the person having a blood pressure of 140 has at least 3 times the risk of stroke than a person maintaining his blood pressure at 120. And that's why actually not only identifying hypertension, it's about being more stringent with the values, being more adherent to the drugs, and having a frequent monitoring and keeping the blood pressure under control would go a long way in reducing the incidence of both stroke as well as MI. Also, as Dr. Sridhar earlier mentioned, amnesia or dementia in elderly. It's also a secondary effect of what we call as multi-infarct state. That means hypertension is affecting multiple small vessels. You have ischemia affecting different parts of the brain, which would actually culminate as the memory loss or dementia in the elderly. So it's majority of the dementia in the elderly, which we call as vascular dementia, is actually a secondary effect of the multi-infarct state. And hypertension, uncontrolled hypertension, is a major risk factor behind all of this.
Thanks a lot, Dr. Gopi, for that crisp and nice answer. Thank you. So let me go to Dr. Sridhar Kasturi. Dr. Kasturi, what role can initiatives like May Measurement Month play in spotlighting resistant hypertension, both for clinicians and the public? Because we have this month dedicated, so this can actually provide a lot of awareness, and it can help us to, track on what we are like otherwise not looking into. Dr. Kasturi, over to you.
Well, thing is, we have to improve the awareness of the consequence of the untreated or uncontrolled hypertension. So suppose if just now Dr. Gopi also mentioned very clearly, for each systolic blood pressure, 20 millimeters of raise and diastolic 10 millimeters of mercury raise, there is a 2-fold increase in the risk of cardiovascular MACE. That means 120 to 140. If you compare 140 to 160, double-fold risk. So higher the hypertension, he is carrying higher the risk of all these consequences. So resistant hypertension, what happens? Resistant hypertension means despite using drugs, the pressure is uncontrollable, high risk. So sometimes patients' psychology also, okay, I'm using medicine, still my pressure is not controlled. Why should you take? He may stop also. So uncontrolled resistant hypertension, the chance of cerebral bleed is very, very high. Cardiac failure is very high. So only thing is, but they have to undergo regular monitoring, and at the same time, we should insist them, are they taking regular medications or not? How about his salt consumption? Is it easy cut down the dietary sodium or not? So they have to educate. We have to educate them properly about the modifiable factors which can reduce the blood pressure. So suppose if the patient uncontrollable blood pressure, suppose if he's exerting, going for exercise, suppose if you're doing strenuous exercise, chance of bleeding because it can shoot and chance of bleeding very, very high. Only thing, these patients, they need a regular monitoring of the blood pressure. Many times what happens when the doctors prescribes, they never check blood pressure at home or in between. And 3 months later, they come back to the doctor 3 months later, 6 months later. That time still inadequately controlled blood pressure. What happened? All these days, he has been continuing the risk of the uncontrolled blood pressure. So that's the reason they have to undergo frequent checkups, whether pressure is adequately controlled or not. And doctor also should focus on a compliance of the drugs. He should take regularly, continuously, and his weight Though sometimes some patients are very meticulous. If you are telling them, they may control the weight. If you are telling them cut down the alcohol, they are ready to do it. Some people are very, very meticulous, but some people are uh, easygoing type. Whatever you tell, sir, give some medications, they may not follow all these things. But at least such patients give adequate doses and adequate number of drugs and see that it's adequately controlled. Only thing, if you people should be educated about the importance of uncontrolled hypertension. We have to educate them. This is asymptomatic. And only thing is, when symptoms develops, most of the time it's advanced stage, uncontrollable stage, or because the effects of the hypertension, like a patient presenting with hypertension, heart failure, or patient presenting with stroke, that time only it will manifest. So that's the reason, don't wait for the symptoms to develop, but to detect early and control it early so that longevity improves, quality of the life improves. Assume that in young age, I will tell one of my patient, I did angioplasty about 15 years ago. She came to us with extensive antivalmy. We did LAD and we saved her. And just 2 years back, our youngest son, he was about 32-year-old, diagnosed to have a hypertension. Though doctor prescribed medication, he ignored. Believe me, he came to hospital with a severe stroke and a massive cerebral bleed, and he underwent lobectomy, recovered, but even today he's a bedridden. Bedridden. Oh, tragedy is the mother is alive, active, but the son is bedridden, and so such type of incidents should not take place. It's a purely lack of the education, purely due to the poor attitude of the patient toward the treatment. The doctor also should focus repeatedly. Please take care of the medication so that in the future we will. Many times doctors, they write medications. See, like a hypertension is not a numerical number. So we have to control the associated risk factors. In diabetics, compared to the controlling the diabetes, controlling the hypertension reduce the more event rate. So compared, if you are maintaining diabetes, you control the smooth control the diabetes versus the persons who control with aggressive antihypertensive, those who are hypertensive, their mortality reduction is much more. So that's the reason hypertension plays a big role. So always we have to focus on these three risk factors like hypertension, diabetes, cholesterol. Not only the controlling hypertension, if you control the cumulative risk will come down. And like obesity, they cut down the obesity, metabolic syndrome, you control it. So overall cardiovascular risk is going to come down. We have to focus on that. And at the same time, we have to, the importance of end organ damage, whether creatinine is elevated, proteinuria is there, retinopathy is there, cardiomyopathy, like hypertrophy is there. All these have to be evaluated. So even doctors also, many times they write antihypertensive, not cardiologists. Many times physicians or MBBS doctors, when they come, write antihypertensive treatment, but they don't look at the lipid profile, they don't look at the HbA1c levels, they don't look at the proteinuria, renal dysfunction is there, they don't evaluate the secondary hypertension. So secondary hypertension needs a specific treatment. So that is a game changer. So these things we have to highlight to the public so that they can undergo, at least they should visit a cardiologist or a specialist who is well versed with the management of hypertension. In the beginning, at least once, they should undergo thorough evaluation with a various tests, deciding it is essential hypertension or secondary hypertension, and they can label the resistant hypertension or not. And they will focus on the compliance of the drugs, dietary modification, lifestyle modification, so that the future miss is going to come down drastically.
So, what are the cost implications of such events for an Indian patient and their family? I think this is a very important question as well. Dr. Parekh, over to you.
Your question and my answer is the summary of what Dr. Arun Gopi, Dr. Kasturi just mentioned and I mentioned. So first question was, what are the relative risks of heart failure, stroke, kidney failure, heart attack? Answer is all of the above. How important is one over another? Answer is all together. So if somebody has a heart attack or heart failure, another is a stroke, would a patient say, okay, I would rather have a heart failure and not have a stroke? Or another patient will say, I have a stroke is better because it's not, there's no pain and heart failure is less. So the question leads to the answer that all of these are very dangerous risk factors. All. Somebody has a kidney which fails, ends up in dialysis. Is it worse than a stroke who is a vegetable, or a heart failure patient who may suddenly die and leave his family, especially a male patient dying, or a mother dying and leaving the child unattended, or father dying and leaving the family unkept in terms of financial difficulty? So the answer to that is all are disabling, all are dangerous. And the summation of Dr. Sridhar, Dr. Gopi, and myself is hypertension has to be aggressively treated. Other message, and I want to spin the story, is to everybody, all patients across India who are on more than 3 medications, please go to Google, check what are the modality of treatment, because these are the patients, the resistant ones, who I can assure you were on 2 or 3 medications at one or another time, were non-compliant. India already has triple medication molecules available. These patients has to understand that they have to seek help, as Dr. Sridhar mentioned, to cardiologist or to special hypertension specialist. If a doctor, a general practitioner, or physician is listening to us today, please, please, once your patients start getting 3 medication, you are entering 4th medication, you may be hiding the fact that when you are giving a triple combination single drug, it's still 3 medication. And then you are adding another triple combination second drug. You are giving him 6 medication and you are telling him, okay, 2 pill le lena, subah or sham, take only 2 pills. No, you are giving him 6 medication and you are still not controlling the blood pressure. There is something going on. Either there's something going on with the patient having resistant hypertension. So to all listeners, the message from me is very simple. Raising awareness, everything is important. But the most important thing is if you take more than 3 medication, your blood pressure is not adequately controlled, seek help.
That's a very important point for the listeners over there from Dr. Parik. So we have more such informations from all our three experts. So let me quickly go to Dr. Gopi. How accessible and adopted are tools like ambulatory BP monitoring or home BP monitoring in early detection? How can they help improve diagnosis rates? How is it actually helping? Yeah, Dr. Gopi.
Yeah, so hypertension, actually, I think the importance of having this May measurement month and everything is all about educating the public to have their blood pressure monitored. And it's not only a single reading, it has to be multiple readings at different times of the day. And then understand what is the normal values and understand how, when they get into the class of being labeled as having a hypertension. So, as I said, most of the time, what happens is they come to the hospital, have their blood pressure checked. So, there are 2 things that can happen. Earlier, as I said, there could be a concept of white coat hypertension, where because of the hospital environment stress, they have a blood pressure which is spuriously high. The actual blood pressure at home for this person might be normal. So, you might be treating a wrong person with a drug which is not needed. The second thing is you might be having masked hypertension, where actually in the clinic his blood pressure is normal, but at home his blood pressure is high. He is actually at risk of having all the side effects of hypertension, which Dr. Parikh and Dr. Kasturi already alluded to. And this patient is already undiagnosed during his clinical visit. So to curtail all of this, for the diagnosis of hypertension, the first step in diagnosis of hypertension is to have a proper blood pressure reading taken. You need to have be sitting in a relaxed position, take your blood pressure reading, not take the first reading. You have to take multiple readings, take the average of it. You should not have been exercising the last 30 minutes. You should not have been taking caffeine or something in the last 30 minutes. So there is a particular way in which the blood pressure has to be taken. And once you have done that in a proper way, you need to repeat it in multiple times. And we generally say that at least 3 readings of more than 140/90 is required for labeling a person as having hypertension. So these are actually made more objective with home blood pressure monitoring and ambulatory blood pressure monitoring. So home blood pressure monitoring, any of the automatic equipments can be used. So the person himself can check his blood pressure at home and keep a record of it. It is important not only in the diagnosis of hypertension, but also for seeing how the drugs are effective in reducing in blood pressure. So not only about getting a diagnosis, but once you started the person on medications, a home blood pressure monitoring will let us know it's better that these patients keep a chart. If they can put these things pinned down on their phone in a notebook, or they can put it in a piece of paper, so that when he comes to the physician, if he shows us the chart, like how's his blood pressure be, because there's actually a diurnal variation of blood pressure which normally happens. Like normally at night we expect the blood pressure to go down, and in the early morning between 6 to 8 there's actually a surge of blood pressure. So if there's a change in these patterns, all of this actually are surrogate markers to say that this person is at higher risk of end organ damage from hypertension. So home blood pressure monitoring helps in both diagnosis as well as ensuring that the drug that he's taking is adequate to ensure that the blood pressure is within the target range. Now, ambulatory blood pressure monitoring is one step ahead, where you have an equipment which you can come to the hospital. It's easily accessible. It's not a complicated equipment. You can actually get it connected, and actually the equipment takes the person's blood pressure every 10 minutes, and you get actually multiple readings for the next 24 hours. So they will give you the average blood pressure monitor throughout the day. They will give you the daytime average blood pressure. They will give you the nighttime average blood pressure. You can see the blood pressure graph. You can also see the heart rate graphs. So there are many things which are actually, many more things which are inferred with ambulatory blood pressure monitoring than the home blood pressure monitoring alone. Because as I said, normally at night, the blood pressure dips. Now, suppose you don't see that, which is called the absence of dipping pattern, these non-dippers. So if there's absence of drop in the blood pressure at night, these people are very high risk of adverse events, both in the cerebral, both in the form of stroke, as well as heart failure, as well as ischemic heart disease, as well as renal failure. So if you find a non-dipper on your ambulatory blood pressure monitoring, if you have sequentially rise in blood pressure along with a rise in the heart rate, it's actually again indicator that these people have increased sympathetic surge. So as Dr. Parekh earlier alluded to, some hormones like adrenaline being raised. Dr. Kasturi also alluded to people with higher sympathetic drive. So these people have a high blood pressure, which coincides with a higher heart rate as well. So if you find a person in the ambulatory blood pressure reading to be having a higher blood pressure as well as a higher heart rate, these kind of patients are going to be clearly benefited with beta blockers as a pharmacological therapy, and probably renal denervation, because that cuts down the excess sympathetic nervous activity that happens in the renal nerves.
Thanks to Dr. Gopi. Let me go to Dr. Sridhar. Dr. Sridhar, how can cardiologists, nephrologists, and diabetologists and the general practitioners work more collaboratively to prevent irreversible cardiac damage from, RHTN? If you can talk about that.
Actually, that's the reason the why multidisciplinary approach is needed for hypertension means associated risk factors. If diabetic patients are there, aggressive control of the diabetes as well as hypertension, it reduces the risk. Suppose HbA1c, if it is usually we have to maintain below 6.5. If it goes by 1 point, goes up by 1 point, we are adding 14% risk. Assume that from 6.5 to sometimes patients will come with a 9, 11. That means that the trajectory, they are going in a bad pathway. So from 6, suppose if they are having a 9, if they are bringing down to almost like a 6.5, almost 42% reduction in the MACE. So always be focused. Hypertension along with the diabetes, if you control, we are reducing the risk to the maximum extent. Similarly, LDL level also we have to check and maintain it in Indian male. If the patient is diabetic, maintain below 70. Already ACS, maintain it below 70. Suppose underwent bypass, multiple angioplasty, maintain below 40 for Indian patients. And why renal means always check the GFR, whether renal involvement is there, proteinuria is there, whether ACE inhibitor is required or AGL2 inhibitor is required. Because AGL2 inhibitor, if they are giving simultaneously along with the hypertensives, renal disease progression is reduced by almost 40%. So that's the reason early intervention, ACE inhibitor and the combination of GL2, definitely it prevents. Suppose if the patient has diabetes, hypertension, lipid, if you aggressively control all these risk factors, we are eliminating the risk. Suppose if you are controlling only one risk factor, you are eliminating the risk related to that risk factor. So that's the reason involve the hypertension. Suppose this hypertension without involvement of the kidney, like a GFR, is it more than 40 or less than 30? To decide, suppose resistant hypertension, GFR is more than 40, still renal denervation is indicated. But less than 30, you can't indicate. And when the GFR less than 30%, always whether other like a potassium sparing drugs, whether are you going to indicate or not, any chance of hyperkalemia when you combine with ACE inhibitors. All these things you can discuss with the nephrologist and diabetes also. You have to involve them mainly for aggressive control of the risk factors. When you involve all these things, again, atherosclerotic disease is the only one entity. But the only thing is depending upon the vascular territory, it affects. Like if the cerebrovascular system, stroke. Similarly, the peripheral vascular system, it affects the gangrene or non-healing ulcers, like a aorta, it can lead to aneurysms. Similarly, cardiac MIs and heart failure and stage renal. If you control these risk factors, indirectly we are preventing many risk factors, many illnesses, which are going to add longevity to the patient and quality of the life. So always prevention is better. Control aggressively risk factors. Definitely, we have to focus on this and take the renal nephrologist opinion, take the diabetes, see that the sugar is aggressively controlled, lipid is aggressively controlled, and whether renal disease progression, is it progressing or regressing? Are you controlling proteinuria? These are all important factors to be considered while treating these patients.
Thanks a lot, Dr. Sridhar. If I can go to Dr. Parekh. So let me ask you a quick question on what are the biggest barriers at the primary care level to catching resistant hypertension early? How can frontline doctors be supported on this?
Very nice question. Again, very simple. It's all going to be education, education, education. Such discussion which we are doing are very important to reach out to the doctors to make them understand that resistant hypertension is a huge menace, huge problem, something our society cannot afford to let it go untreated. Beside general education, I truly believe areas like radio, like television, like billboards, etc., in malls, in various places has to be promoted. Coming back to the doctors who are frontline, it's very important for everybody, including media, to start educating them that resistant hypertension, exactly what it is. Many doctors may not be aware, as I mentioned earlier, that giving them 2 pills, each one with a triple combination, is actually resistant hypertension because they are taking 6 different tablets and the blood pressure is not controlled. Second area is that they should be educated that there is a treatment. There is a treatment for all this group of patients, whether it's additional medications or potent medications, or finding in the resistant hypertension, if there is secondary hypertension, like one of the common things in some of this patient is renal artery narrowing, which can be picked up with Doppler exam, or rare cases of pheochromocytoma. It's a rare condition where there is increased hormone development in the body, which causes hypertension, or plain and simple resistant hypertension, which is idiopathic, which means there is no real cause, it's just resistant. So primary doctors, physicians, as well as general practitioners has to be educated again and again that there is a treatment beyond just medical treatment of conventional drugs. And second thing is teach these patients to take home blood pressures. I truly believe all hypertensions, even if they're on single drug, double drug, can afford a blood pressure machine, which is anywhere around 1,500 rupees to 2,000-3,000 rupees. And that is a few years cost in a single cost. So you are talking of maybe 50 rupees a month kind of cost if you cover over a 5-year. This is machine's life. Now, 4 or 5 years, they work very well. that every hypertensive should have a machine at home, which can be used not only by him, but other family members. They should be taught. So my solution is education, education, education.
Yeah, Dr. Parik, an extension of the same question because we have touched prevalence, awareness, diagnosis, now on the treatment part. What existing national programs or registries are currently in place in India to track and tackle resistant hypertension? Do we have?
There are a couple of programs. There's Hypertension Council of India. There is again National Hypertension Agency. They keep on tracking. But I can tell you the enormity of a 1.4 billion population with a prevalence of hypertension anywhere from 10-20%. We are talking of enormous that all of these agencies, which still do a very good job, it lands upon both population at large, people, lay people, people who are going to listen to this kind of webinars, which are fantastic, and doctors. It comes upon doctors to identify these patients. So yes, we do have huge councils, very well managed, but against that council, we are facing an epidemic of enormous population where we are talking of entire population of America, which is 300 million. We are considering more than that hypertensive in just one country, India. So you can see the enormity of that.
Thanks a lot, Dr. Parik. Let me go to Dr. Gopi. Dr. Gopi, how do we engage patients to take control of their BP? I think all three of you have been talking about how it is difficult at times to convince the patients to take control of their own BP and seek specialist intervention when first line treatments fail. So also, if you can explain the renal denervations mechanism and real world potential in India, if you can touch upon both.
So that's a very valid thing because see, first of all, it's all about, as if any disease, it's all about prevention is better than cure. So for every healthy person, so-called healthy person who has probably not checked his blood pressure, it's first mandatory that he gets an equipment and gets blood pressure checked at home repeatedly. He and all his family members need to get checked. You might have a surprise. You might have many people who have been undiagnosed, and at least that will at least help them seek medical attention for the first time. For people who are on drugs, they need to have their home blood pressure monitored and seek again a physician advice once their blood pressure is not controlled on a particular class of drugs, because there are numerous kind of drugs which are available. There's different combinations which are available. The most important issue with hypertension treatment is the non-compliance. In fact, combination pills are available, fixed dose combination pills are available, which will improve the compliance. So they can seek a physician's help to have the pills. Once they are to get the pills reduced, they can have combination drugs taken. And then, despite all of these measures, if the person's blood pressure remains uncontrolled, as was already alluded to, resistant hypertension having blood pressure more than 140/90, despite 3 classes of drugs, one of which has to be a diuretic, or refractory hypertension, meaning which the blood pressure is still not controlled despite being on 5 classes of drugs for at least 3 months duration. If a person understands that he falls into this category, he needs more specialist help. So he needs to meet a cardiologist or a hypertension specialist. There's a particular pathway through which he would go through, ensuring that the blood pressure, first thing is ensuring that the blood pressure is properly taken, ruling out pseudo hypertension with a proper home blood pressure monitoring, as well as ambulatory blood pressure monitoring, ruling out secondary causes of hypertension like a renal parenchymal disease or a renovascular disease or hormonal issues like adrenal tumors or pheochromocyte tumor, or taking in some of these drugs, even like steroids, can cause hypertension. So understanding any secondary causes of hypertension which can be detected and treated. After all of this has been excluded, once we look at the person's renal function as well, suppose as GFR, which is a glomerular filtration rate, is more than 40 ml per minute per meter square, and his blood pressure is still not controlled despite 3 classes of drugs, he would qualify for this novel therapy, which is called renal denervation. So the premise of renal denervation is that most of these resistant hypertension is neurogenic. It's predominantly because of excessive activity of sympathetic nerves around the renal arteries. So in these patients, we find a lot of adrenaline hormones being secreted from these renal nerves. So if you look at these patients, they tend to have higher resting heart rates. They tend to have higher daytime heart rates. Their arteries are more stiff. If you look the hormonal assays like a urine metanephrine assay, their urine metanephrine assays are all elevated. So all of this indicate that it is the excessive sympathetic drive, which is the major pathophysiologic substrate behind the so-called resistant hypertension. So one of the ways to reduce the sympathetic drive is to target these nerves which are overactive. And we have found a suitable target. These nerves actually run around the arteries of the kidneys. They have a specific branching pattern where they are not seen in the main trunk. They are particularly seen around the branch arteries and the distalmost part of the arteries. They go along with the arteries, and around the arteries there is a fat pad which is there. The nerves are actually housed in these fat pads. So for that, what we try to do is just like an angioplasty. Renal denervation is a very simple procedure. It just requires 1 day of hospital stay, a small puncture in the right groin. We take in a catheter into the renal artery. We take an angiogram of the renal artery, rule out any significant obstructive disease in the renal artery, and we identify the part of the renal artery which would have these nerves which are out of the renal parenchyma, away from these branching areas and away from the origin of the renal artery. We decide on which are the areas which we need to target. And now we have a newer system which is there, which is totally artificial intelligence based, which uses a very small catheter, which is almost just 4 French, which means it's just a 1.2 mm catheter, which is taken into the renal artery. And it actually goes in just like like how you do an angioplasty over the wire into this renal artery. We keep this catheter there. And once the catheter comes in contact with the renal artery, it actually emits a mode of energy which is called radio frequency current, which damages the adipose tissue around the renal artery. And inside this adipose tissue is where all these renal nerves are. So once you have these electrodes there, it delivers radio frequency current there. It damages the renal nerves and only selectively damages renal. That's the beauty of this therapy. So this therapy has been there for a decade now, but earlier it was not done in such a scientific way. So the results were not encouraging. But the current system, which is totally AI-based, ensure that from each electrode, there is a positive response feedback based on parameters like the temperature at the electrode and the impedance, which ensures that the electrode is in contact with the renal artery, as well as it is doing its work by burning around the fat, which houses the nerves. And so when it is done in this AI-based positive response feedback, it's absolutely safe. And once you do this, there is no collateral damage. It actually ablates. We call it a denervation or ablation of the renal nerves. Once it ablates the renal nerves, the good thing about these renal nerves are these renal nerves do not have a protective covering, which is called a myelin. So once these nerves are damaged, these nerves are damaged permanently. So the advantage is once you have done this renal denervation procedure, these nerves don't regenerate. And contrary to the drug, so suppose your person is hypertensive, he's taking a drug. The drug has a peak and trough effect. So there will be a time when the drug has a peak effect where the blood pressure reduces. But after a particular time, the effect of the drug goes off and the blood pressure will start surging on again. But with renal denervation, since these nerves are permanently damaged, there's an always on effect. So once a single time procedure, the person's blood pressure starts coming under control and the control remains sustained for years duration. Like you might at the index procedure, you might have a reduction of say 10 to 20 mm reduction, but progressively as you see over years time, there is a sustained reduction of blood pressure and you will find this blood pressure reduction sustaining even as long as 9 to 10 years as per the studies. The other advantage of this is there is a progressive reduction. So at the index time, you might have a 10 or 20 mm reduction, but the advantage is you are ablating these nerves at a particular site. Distal to the site of ablation, these nerves actually have progressive axonal damage. There will be a damage distal to the site of ablation as well. So cumulatively over time, now you might have a 20 mm reduction. At the end of 2 or 3 years, you might go to a 30 mm reduction. At the end of 5 years, it might go to a 40 mm reduction. So compared to taking a drug which you're taking every day, multiple times in a day, continuously for years together, here you have a minimally invasive, percutaneously done procedure requiring 1 day of hospital stay, done totally under local anesthesia, which gives you immediate reduction, a sustained reduction, and a progressive reduction, which is always on. And the best part is it is almost free of very side effects. This has been well studied. They have looked whether you damage the renal arteries or not. You don't damage in renal arteries. All the studies have negated this concept that you will have any injury to the renal arteries despite ablating in the renal arteries. There is no damage to surrounding the kidney tissue or the ureters or the lymph nodes which are surrounding there. There are no other major vascular issues. So it's a very safe procedure, highly effective, and having a sustained benefit over at least more than a decade after the index procedure.
Thanks a lot, Dr. Gopi. That was an elaborate answer. Thank you. Let me go to Dr. Sridhar quickly. Dr. Sridhar, keep it little concise. If you can keep it concise. So nearly 50% of patients do not adhere to their medication regimens, often skipping doses, which you had also mentioned earlier, or discontinuing treatment when they feel improved or when they feel or encounter adverse effects is not there. So how does renal denervation help such patients? I think we had got the answer from Dr. Gopi as well. If you can keep it, Chris.
Dr. Gopi nicely described about the RDN
Yeah,
procedure.
the entire
Really,
process.
entire thing beautifully narrated.
Yeah,
I
Dr.
think
Sridhar, if you can also share any success stories where early detection or referral to a hypertension clinic made a clear difference. If you can touch upon
no,
that.
that see if the hypertension like a resistant, sometimes poor complaints. Some patients are reluctant. In such patients also, because indirectly uncontrolled hypertension is going to have a deleterious effects. So definitely it has to be controlled. If patient is having a poor complaints, we have to educate the family members of the need to control the blood pressure adequately. And sometimes patients they may not tolerate. The doctors also try multiple drugs. Every drug a patient is going to have uncomfortable because previously he was asymptomatic. Any drug is a drug. So because the side effects are, some patients, they tolerate it very well. So when intolerance is there, tend to make it irregular. In such cases, RDN definitely has a big role. In such patients, we can avoid the pill. At least studies have shown even mild, moderate hypertension also, they studied it's effectively control the blood pressure. So not only resistant hypertension, if the poorly controlled and due to lack of compliance and intolerance to drugs, in such case also, clinician can give an option after multiple see, always we have to educate them about the importance of taking drugs, and we have to educate them if you are developing any side effects or if you are not tolerating drugs, you come back to us so that we can substitute with other drugs. Multiple steps should be taken. Despite multiple attempts, still uncontrolled. In such cases, this can be offered as an alternative therapy.
Thanks a lot, Dr. Sridhar. Before I'm concluding this, informative webinar, let me quickly go to all the three experts here. Any three quick pointers for the patients, how to take control of the BP? Quick pointers. Dr. Sridhar, if you want to go first.
Yeah, only thing is don't underestimate the problem and adequately control it. Whether you take drug or RDN, whatever it may be, smooth control of blood pressure, improve the long-term outcomes. In terms of death and cardiovascular MACE rate, definitely we should not underestimate the problem. Though it's asymptomatic, it can lead to more symptoms in the latter stages. Treat it aggressively.
Okay, let me go to Dr. Gopi. Three quick pointers for the patients who are listening in.
Yeah, so
Patients in the
3
complex.
points. Yeah, monitor your blood pressure. If you're hypertensive, be compliant with your drug. And if you're still your blood pressure is not under control, seek help. Meet a specialist.
Dr. Parekh, your pointers.
My pointer is stories. 2015, we did few patients, 4 patients to be precise, RDN. I've been following them. Interestingly, all 4 have done very well. One of them, I've done even a couple of coronary angioplasties till recently. We did another patient just few months ago on 5 medication, blood pressure 200 plus, slightly obese lady, 80 kilograms, 5 feet 6 inch. Absolutely devastated because of her high blood pressure, multiple admissions, headaches, inability to have a functional lifestyle. We did RDN about 4-6 months ago. She's doing fantastic. Her medication has come down from 5 to 3. Her average blood pressure, which was about 180 on 5 medication, is down to 120 range on only 2 to 3 medications. So my pointer is RDN works, and like Dr. Gopi said, it works over a decade period. I have a personal experience of it. So my pointer again is seek help. Seek help if you are on multiple medications.
So, as we heard the experts here, and as we conclude today's session on resistant hypertension, we are reminded for a crucial truth. While hypertension is a silent killer, resistant hypertension is more complex, persistent, and often underdiagnosed. So, May Measurement Month serves as an important annual reminder on resistant hypertension and the need to take control of BP for continuous awareness, early detection and proactive management is very crucial. And I hope we had a good round of discussion on a very pertinent topic. Thanks a lot to each of the experts who had joined us and who had given their expertise. Thank you so much.
For you,
Thank you very
pleasure
much.
to
Thank
see
you.
all of you.